All right, so this is the beginning of MedSurg 2. This is the neuro portion. However, I really want to focus on the concept of increased intracranial pressure. It can be seen as ICP, and it's a really important concept. There are many factors that contribute to it, but I really want to hammer down the importance of this concept. And so here's the concept of it here, and it seems pretty self-explanatory. It goes into the priority assessments, such as the level of consciousness, pupillary reaction, cranial nerves, movement and sensation, seizures. The temperature is a really big one too. Pulse pressure and respiratory rate and rhythm, which we're going to see how this plays along with the Cushing's triad. Okay, so to have normal intracranial regulation, you're going to be normally alert and orientated times 4. Pupils will equally react and restrict to light and accommodation. All cranial nerves should be intact. Movements of the extremities are all equal with full sensation, full muscle strength. No seizures, and normal vital signs. And then abnormal intracranial regulation is someone's going to be disorientated or even obtunded. So it's just that swelling. I would even take this a step further and kind of incorporate inflammation and perfusion as a concept as well. So you would have abnormal cranial nerves. So if there's edema or that swelling that's building up or blood, it's going to be pressing down on those nerves. It makes sense how a lot of these affect that. Seizure activity, hyper or hypothermia, especially with that hypothalamus, that controls, that regulates a lot of your hormones, you know, how to maintain that homeostasis in your body. Okay. Abnormal respiration patterns and that pulse pressure, that widening pulse pressure, which we should know is the systolic blood pressure minus the diastolic blood pressure. Okay, so we're going to see that force of contraction, that squeezing part, is going to be a lot higher pressure. Okay. However, the heart rate will be going down. Okay. And the pupils can be unequal or they can be unreactive. Priority labs, glucose, that is something that the brain needs. Okay, that's its energy source. Sodium, a lot of sodium and neuro goes together. That's a lot of your action potentials. That's sodium is outside of the cell and it goes inside, and it's how everything works basically. Material blood gases, and then serum osmolality. Okay. And see, related concepts, cognition, perfusion. Okay. Some objectives of ICP, I should be able to define what increased intracranial pressure is. I should have an understanding of the pathophysiology, and I should be able to recognize the signs and symptoms, especially the early signs. I should be able to know how to implement some of the nursing interventions, get familiar with the medications, and the treatments, I kind of left that out just because we'll cover that over in lecture tomorrow. So increased intracranial pressure, this is a true medical emergency. Pressure is inside of the skull, it's increasing, and just keep in mind that that skull has limited space, okay? ICP is the pressure created by the cerebral spinal fluid, brain tissue. If it's brain tissue, that could be caused from, inflammation, swelling, or a tumor, or blood within the skull, okay? And you can measure the ICP within those lateral ventricles, okay? And there is a probe they put in there. I didn't include that in this part of the lecture. But that probe that they do put in there measures it. It should be between 5 and 15. And anything over 20 millimeters of mercury needs immediate treatment. Pathophysiology of increased ICP. So the skull is very hard and limited on how much it can expand. If there is expansion inside the skull, this can lead to increased pressure. And there are 3 factors that can alter intracranial pressure. The brain itself. Again, the brain is a factor when it swells. And think of inflammation, or think of a mass like a tumor or growth within this brain tissue. Cerebrospinal fluid, or CSF. And think about infections or a blockage that causes it to back up into the brain if there's a blockage here or an injury here, or an infection. You know, it's going to cause inflammation, okay? And blood. And think of those blood vessels. Think about how hypertension over time can weaken the endothelial walls of the blood vessels, including that of the brain. And think of other various ways blood can be a factor. Either a rupture of a blood vessel or a blockage, like from a clot that can burst, or an injury that causes massive bleeding within those vessels. The Monroe-Kelly hypothesis. This is going to help with the pathophysiology. If one of the 3 factors that can alter intracranial pressure increases, the other 2 must decrease their volume to help alleviate that pressure. So when there's an increase in ICP, the body can temporarily compensate for it by shifting the cerebrospinal fluid to like other areas of the brain or back to the spinal cord. This can alter blood volume going to the brain through vasoconstriction. Prolonged pressure, if it goes on for so long, it just cannot sustain this and it will no longer be able to compensate, okay? Essentially, ICP can be affected by cerebrospinal fluid, blood in the brain, and the brain tissue itself. And these 3 factors help to maintain cerebral perfusion pressure. And that normal is 60 to 100 grams or 100 millimeters of mercury. Okay, so just keep in mind, to sum this all up, if one of these factors, the blood, if there's too much blood in the brain, the other 2 have to decrease or do something to alleviate. The worst thing the brain can do is herniate out of there, but it's trying to alleviate that pressure, okay? And there are fluctuations of intracranial pressure that depends on these factors. A person's body temperature, the oxygenation status, especially carbon dioxide and O2 levels, body positioning, arterial and venous pressure, and anything that can increase intra-abdominal or thoracic pressure, like vomiting or bearing down. So just remember that the brain needs oxygen and proper nutrients so the brain can do its job. The brain can alter the cerebral perfusion pressure by vasoconstriction or vasodilation. And it always seems like any compensatory mechanism, if prolonged, will do more harm than good. So say carbon dioxide levels are very high. Someone has a head injury, they're bradypneic or they're hypoventilating, their respirations are really low. They're not getting adequate oxygen and they're just they're holding onto that carbon dioxide. The extra carbon dioxide or hypercapnia will cause vasodilation. So always remember that if there's too much carbon dioxide, the vessels are going to dilate. So this is going to have more blood going to the brain, and this is just going to increase that intracranial pressure even more, okay? And just looking at these factors that can cause fluctuations with intracranial pressure, and think of ways that each one will affect ICP. And now, think of what you as the nurse is going to do. And in a few next slides, the nursing interventions are going to be based off of these factors that cause these fluctuations. Okay, So cerebral perfusion pressure, the normal range is 60 to 100 millimeters of mercury. So we have the CPP equals that map, and remember that anything over 65 is adequate, minus the intracranial pressure. So it has to be between 5 and 15. And that together has to be between 60 and 100. All right? So CPP will be compromised if there's increased intracranial pressure. If the map starts to fall, anything under 65 starts dropping, then the CPP will drop and the brain will be deprived of oxygen. And the brain not getting adequate perfusion will cause that brain tissue to die. So just keep in mind that for adequate perfusion, that map needs to be over 65. And normal ICP needs to be between 5 and 15. And any ICP over 20 requires immediate intervention, all right? And the body itself will try to compensate for that in the meantime. So what are some of the causes of increased intracranial pressure? Well, an injury to the head, an increase in cerebrospinal fluid. Remember I talked about any blockage that causes it to back up, or inflammation, hemorrhage, either from a hemorrhagic stroke, an aneurysm bursting, a hematoma that's in that subdural or epidural spaces that's bleeding in between structures in the brain, hydrocephalus. This is a buildup of that CSF in the brain. It normally flows through the brain and the spinal cord and enters the bloodstream. But if it's blocked or there's too much is made, that's what's going to cause it to back up into the brain. Okay? A tumor, that's that brain tissue overgrowth. And it's putting pressure on that brain. And then encephalitis, I can't say that word, which is just inflammation of the brain tissue. Or meningitis, which is inflammation of the membrane covering that spinal cord and brain. And there's different types. There's bacterial and viral. We're going to discuss that more in lecture, but I really just want to get down the main concepts. Okay. Increased intracranial pressure. Limited blood to brain is because of the intracranial pressure. The brain is getting squeezed and squished, which leads to ischemia. Then swelling and edema occurs, and if this goes untreated, the brain will herniate. Do you see that? Or be displaced. It will like totally shift, okay? Now, displacement can cause the vital areas to be pressed up against. Examples like areas that control breathing, like right here in the brainstem. Look at that right there. I mean, it causes that to be clamped down. So just look at this and just think of it more of a cascade, okay? And here's that, traumatic subdural hematoma. Someone gets hit in the head. Blood is building up. I mean, you can see it shifting, or actually herniating out of the skull, or herniating here, or just clamping down on that brainstem. What does the body do when that cerebral perfusion pressure is decreased from intracranial pressure? Well, the systolic pressure starts to increase. Remember, that's the squeezing of the heart, of those ventricles, because the body is starting to prioritize getting more oxygen to the brain by sending more blood, which increases ICP even more. Carbon dioxide is starting to build up. So arteries dilate to send more blood to the brain. And that's just increasing ICP even more. All focus is on the brain. It needs oxygen. It's getting deprived of it. It's getting squeezed. Blood is increasing, clamping on veins, and causing a decrease of venous return back to the heart. Now you have an increase in swelling or inflammation. Now there's less and less room in the skull, so this is increased in more ICP. And as you can see, that every compensatory mechanism keeps making ICP more and more worse. And that is why it is so crucial to know and recognize the early signs. So know the signs, especially early signs of ICP. Why is it so important to know these early signs? Well, as the slide before indicates, every attempt that the body makes to keep perfusion or sending oxygen to the brain is just making it worse. So we need to stop it before it clamps down to the brainstem, which the brainstem regulates breathing. So the very earliest sign is just that change in level of consciousness. They start getting restlessness, confused, having trouble with everyday normal movement. They're unable to respond to very basic questions, aphasia. They can get some slurred speech, okay? Headaches, and just think of why headaches. It's that building of that pressure. Vomiting, which is projectile without nausea, okay? That pressure is pushing down on that center of the brain. They can get seizures, a positive Babinski reflex. So remember, that's only normal in newborns, where you run your finger on the bottom or the sole of their feet and they fan out their toes. Weakness on one side of the body, or deterioration of a motor function. So more signs that intracranial pressure is progressing. You'll start seeing vision changes. They'll get double vision or diplopia. Swelling of that optic nerve or papilledema. Pupil size changes. It can either decrease or increase or cause unequal in size. So one would be larger than the other. And dull eyes, that's when positioning of a patient, their eyes are fixed. It's like staying straight or midline. That, when you move a patient, their eyes should go the opposite direction. But if they're staying fixed, that's a really bad sign. And it indicates brainstem damage. Positioning, they can have a decorticate or deliberate or flaccid posture. And this slide right here is a really good example of it. So that decorticate, it's a flexor. They're flexing. Their hands are making a C, and it's to the core of their body. Okay? It moves in towards the cord. And this is usually problems with the cervical spine or that cerebral hemisphere. Okay? And remember the decerebrate, the extensor, remember all the E's, extensor, that's the worst kind. Even the arms are like an E, it's to the side, but they're flexed out. So these are problems within the midbrain or the pons. And Cushing's triad, this is a late sign. And eventually this patient's going to be unconscious because there's only so much space in the skull, okay? And that increased systolic blood pressure. And remember, body is prioritizing getting oxygenated blood to the brain, but it's only making ICP worse. That's why you'd see widening pulse pressure, which is that increased systolic blood pressure and decrease in diastolic blood pressure. That's the widening pulse pressure. It's mainly taking the systolic and minusing the diastolic, okay? You'll see a decrease in heart rate. Those baroreceptor reflex cause the heart rate to drop with the intention to decrease blood pressure, just like your beta blockers and calcium channel blockers. Or that swelling in the brain can compress down on the vagus nerve to cause a decrease in heart rate. And you're going to see irregular decreased breathing. That's where you'll see those Shane-Stokes breathing, where there's periods of hyperventilation, then nothing, apnea, or no breathing at all. Again, that increased intracranial pressure is clamping down on the medulla brainstem that controls breathing. And here you can see a nice little diagram here, pictures of the Cushing's triad, the three primary signs that often indicate an increase of intracranial pressure. And remember, these are late. So, and it's the opposite of shock. So you have an increase of systolic blood pressure, decrease heart rate, and decrease respirations. And I would even say irregular as well. Okay. So, some nursing interventions. Keep in mind that the goal is to prevent furthering the increase of intracranial pressure. And the prior slides that we mentioned, the factors that can cause ICP to fluctuate, a lot of our interventions are going to be based on that. So there are many reasons for an increase in temperature. There's damage to the hypothalamus, infection, or dehydration. And also, an important point to mention is if a patient's unconscious, do not take their temperature orally or in their axilla. So, why do we want to control temperature? Well, increased temperature or hyperthermia can cause an increase in ICP. Hyperthermia increases blood flow and demands more metabolic activity on the patient. So, we want to monitor vital signs, especially temperature. Give antipyretics, okay? Remove blankets, decrease temperature in their room, apply ice packs as needed, but don't go overboard. You really want to prevent shivering because that attempt starts to increase body's metabolic needs, and we don't want to do that. We want to reserve those. And managing oxygenation status is so important. And just think about how we mentioned how carbon dioxide is increased when vasodilation occurs, because the body thinks it's helping. And more blood is just going to the brain. Well, we want to facilitate vasoconstriction to inhibit sending more blood to an already increased intracranial pressure, okay? So we're going to want to manage their hypercapnia and hypoxemia. We monitor their ABGs. We do so with a pulse ox as well. We provide suctioning as needed, okay? I should really cross that out. That should not be routine. And if mechanically ventilated, we're going to keep that partial oxygenation low, okay? Now, positioning the head of the bed to 30 degrees will help blood return to the heart. So if the neck is flexed, then it will decrease venous blood flow back to the heart, okay? Keeping the neck straight will help facilitate blood flow away from the blood or from the brain and back to the heart. And this is a weird one too, because I would never think of this, but if the hips are flexed, then what it's doing is increasing the intra-abdominal and thoracic pressure. So remember that we don't want to increase that intra-abdominal thoracic pressure, like having them bear down or doing the Valsalva maneuver or even vomiting, okay? So head of bed, 30 degrees, neck straight, head midline, no flexion of the neck or the hips, okay? And which brings us next to avoid strenuous activity, like vomiting or constipation. So we want to give them stool softeners. We want to keep their environment calm. And just think about how frequently you should do all their neuro checks and compare, trend, and ask yourself, are they getting better or worse? How do I know? Because, or just do neuro checks per facility protocol, often more frequently, especially with someone that's had some head trauma. So you want to measure their level of consciousness, do the Glasgow Coma Scale. Remember, 15 is the highest, 3 is the lowest. Implement seizure precautions. So we want to pad the bed rails and have a yonker nearby with a suction as well, a functioning suction kit. Nutrition management, either enteral or parenteral, within 3 days, especially for those unconscious patients, okay? Collaborative care for increased intracranial pressure. I'm going to focus on drug therapy, like diuretics. We want to give mannitol or osmotrol, and hypertonic saline solution, like a 3% normal saline. Both 3% hypertonic saline and mannitol can effectively reduce intracranial pressure. 3% hypertonic saline has more of a sustained effect on intracranial pressure and can effectively increase cerebral perfusion pressure, which is the goal. Okay? So these have an osmotic effect, so it pulls water out or decreases edema in the brain. So it's pulling all that fluid off of the brain back into the blood. That's what we want. Okay, because just think about how water moves from a low concentration to high concentration. We want to monitor their fluid and electrolytes. That's really important. And in doing so, we want to monitor blood pressure and especially sodium. I know it's kind of redundant. I have it there, but it's really important. Okay. And so let's talk a little bit more about mannitol. It is a concentrated type of sugar. When this drug enters the blood, it's very concentrated, and it draws water that is pooling in the brain back into the blood. And this type of diuretic is filtered through the glomerulus and not reabsorbed through the renal tubules. Because of this, it creates an osmotic pressure that will pull water and electrolytes like sodium and chloride from the blood. It just won't be reabsorbed and excreted out. So that's why we really want to watch the sodium, okay? And, we want to watch for fluid overload as well. We want to make sure that, to prevent water intoxication and depletion. Fluid volume overload, which signs and symptoms like heart failure, pulmonary edema, monitor renal functioning, urine output. They shouldn't be retaining it. Electrolytes. You don't want to give that to patients that have cerebral hemorrhage or anuria, which means no urine output. Patient will report dry mouth and thirsty. So you really want to provide mouth care and watch fluids, IV, oral, urine output, eyes and nose, the retention of water. We would have more edema management meds that may be ordered, like loop diuretics to remove fluid from the brain and maintain a negative fluid balance. And corticosteroids, just think about inflammation. That's there to control that. We would give that Decadron. But it won't be for those TBI patients. Okay, that traumatic brain injury patients. We can give anti-seizure medications like Dilantin, antipyretics, acetaminophen, and implement other cooling measures. Some sedatives we would give them, like propofol, Versed, or Precedex. We want to be careful with their respiratory rate when we do give that to them. And these patients are still aware, so they're probably going to be in pain. So we want to give them analgesics, codeine, morphine, fentanyl, Dilaudid. And so you really want to be careful with these just because their respiratory rate is already going to be low. That's if they're in that late stage. And barbiturates, they would give that. I think that would probably be a better alternative than the sedatives. But that is just my wrap up of the concept of ICP. I think it's a really important one. In lecture, we're going to go over more, but I really want to get down kind of the important parts of intracranial pressure.